throughout, and we will try our best to respond to those to the best of our ability. And finally, we'll be sending out an evaluation link at the end of this because your feedback is very important to us and we really want to know. Great, okay, so let's get going. And so this is the agenda for today, as you can see. And it's quite timely given that November marks the Lung Cancer Awareness Month. And as you can see, this agenda will make up a couple of key priorities here today. And what we'd like to cover, generally speaking, is to share some key information about the importance of early diagnosis within lung cancer. And number two, to improve our referral management and help us within primary care. So what I'll do now is I'll kick off by starting to provide a little bit of overview about lung cancer and the disease and the impact of the pandemic. So here we've got some key facts about lung cancer. And what this slide really does illustrate is how prevalent lung cancer is. We all know that lung cancer is probably one of England's biggest cause of cancer deaths, and many people will die from lung cancer and are diagnosed each year within our country. Now, we know that the biggest risk factor for lung cancer is smoking, and there are other risk factors that we'll talk about later on. But it's just something to also bear in mind is that there are a proportion of patients that are never smokers or have smoked few cigarettes, which are less than about 100 cigarettes in their lifetime. They are known as never smokers, who can still be diagnosed with lung cancer. And over 50% of lung cancer patients in the UK are also diagnosed at a later stage. And it's not always too late for curative treatment. And so really the key message that we're trying to get across is that early diagnosis is key, because we know that early diagnosis means better prognosis, and earlier diagnosis means a lower treatment morbidity, an improvement in the patient's quality of life, and better experience of care. So please do think about lung cancer in patients. We do know that it's prevalent, and do think about it in the non or never smoker category as well as smokers. Can I have next slide, please? So here, what I guess we're trying to illustrate is that the association between lung cancer and health and socioeconomic deprivation, and trying to pull out some of the key issues about health inequalities. Now, really, we do know that it's very well documented that lung cancer is more prevalent and survival is poorest in those individuals who are more deprived. According to Cancer Research UK, there's roughly around about 27,000 patients, cases of cancer each year that are associated with socioeconomic deprivation. Now, if you look at the table on the right-hand side, the series of tables, what this is trying to reflect is our concept of first treatments. Now, what that means is that our first treatments really are a proxy for cancer diagnosis. And we've got some data here in 2019 compared to 2021. So we're thinking back pre-COVID levels and pre-COVID time to currently, and we make that comparison. And what you can see is that there's generally been a recovery to baseline levels across all demographics, except particularly in those areas there is highest level of deprivation in a younger age group between 0 and 49 and in BAME communities. So it's important for us to actually consider that these patients may be not approaching their GP. They may have higher risks for lung cancer, and we must be aware of this issue. Next slide, please. And so now what we've got is actually a little bit of data, really, just to put it in context around about where we are within Northwest London. Now, we can have a look here at this particular slide, and actually what it shows that within our monthly 2-week wait first seen patients, that our levels are seemingly actually getting back now to pre-pandemic levels, back to September 2019. And trust performance seems to be pretty good in terms of referrals seen within 2 weeks earlier on within May and July. And things have generally kind of recovered moving forward. So this is really positive. Next slide, please. This is a little bit of a breakdown between the different trusts across Northwest London. As you can see, there is some disparity here between the different trusts, and it highlights the variation. We need to be aware of this depending on where we are practicing. Now, within September, you can see that things have recovered really compared to September 2019 in terms of lung and 2-week waits. There was a slight issue within August, and the reason behind this is not clear, but that has been evaluated locally within secondary care. So this particular slide has a look at the lung backlog, and this is for patients that are waiting 63 days or more, those that are on a 62-day pathway, and for suspected lung cancer. And there are two different lines here. One is GP referrals and second is consultant upgrades. And there has been, as you can see, variation here, and patients that were waiting more than 62 days generally was at the height of the third lockdown between kind of mid-January and early February. And as you'd expect, things have fluctuated but have come down to an even baseline. Great, so this is the concept of first treatments, which I referred to earlier on, and as we know is a proxy for our cancer diagnosis, given the way that we collect our data. And so this actually demonstrates that the number of patients accessing first treatments in comparison to last year and the year before, and you'll see that the deficit in the missing first treatments has pretty much entirely reduced within North West London, with greater numbers accessing first treatments currently and right now. Here, this also reflects this particular that graph, and as you can see, the recovery in first treatments. Interestingly, if you have a look down the palliative care column, that things have actually increased in the number of patients with lung cancer that have been going down in palliative care, which may suggest that we're having later stage lung cancer diagnoses that are coming through. Next slide, please. So this, so just staying on the concept of first treatments, and there is a pilot project that was done within Wandsworth, within Southwest London, where some learning may be helpful for us here, where Wandsworth, the data actually identified that there may have been a higher number of missing first treatments for lung cancer, and within general practice, within initial search was done within 7 practices with the highest deprivation. And they had a look at patients over the age of 40 with smoking status, and they had within their primary care notes a couple of episodes or more of respiratory symptoms that were coded. Those patients that were identified through that initial audit were therefore brought in and had a clinical review and follow-up investigations such as a chest x-ray and referral down an appropriate pathway if was needed. The 25 patients were identified within the initial search, and within those, as you can see, a breakdown of what happened afterwards and within that particular table. So some are within secondary care review, some of them had a chest x-ray organised, and there has been a cancer that has been diagnosed. Interestingly, that there are patients that come through the non-site specific RDC pathway within St George's, that's local to Wandsworth, and 3 patients that were diagnosed with lung cancer had weight loss symptoms, which was not included in this search. So I guess what I'm trying to reflect here is that even though our data within North West London suggests that we have recovered post-pandemic, or compared to pre-pandemic levels rather, there may be some learning actually that we can take from Southwest London. We can see that their data suggested that they were missing some lung cancers, and it highlights the importance of being aware of lung cancer, and we will come on to the importance of this in our next few slides. So now what I'm going to do is hand over to Jane, and we're going to talk about our local RMP pilots for lung cancer screening.
Brilliant, thanks. Hi everyone. So I'm the RMP project manager for the Targeted Lung Health Checks programme. This is a Cancer Alliance project that we've been running since 2017, and it's very much around early diagnosis. It's about finding patients who are asymptomatic but are at an increased risk of lung cancer. So similar to that pilot, we're looking at those aged 55 to 74 with a history of smoking, and the process is that they're invited for a lung health check with a nurse who takes them through some questions that inform a risk score. If they're above the risk score, then they're offered a low dose CT scan. Again, this is we are hoping that we might find some of those patients that didn't present during COVID. And then also in 2020, we joined the national programme, which is piloting this approach to finding early lung cancers in 30 sites across England. So we started in Hammersmith and Fulham and Hillingdon. These were identified through some data analysis of need against lung cancer prevalence, smoking rates, deprivation. And our first pilot worked with a handful of GPs, but we now have the funding for every GP practice in those 2 boroughs to access the programme. It's delivered by the Royal Brompton Hospital, and the health check is done on the phone. Hammersmith and Fulham patients, if they need a scan, will go into the Brompton, the Brompton, and Hillingdon patients go to a mobile scanner in Tesco's. If you can move on to the next slide. Yeah, so just to let you know, so we've got this many GPs that are signed up, but as I say, every practice can join up. So if you aren't on the program and would like to, just email me and we can take that forward. And there was just a little bit of data for you there. In the last year, obviously we did have a dip across the COVID waves because we didn't bring patients in, but yeah, so those are the health checks that we've done and the scans. So some patients, if we find nodules, we followed them up over a year. The lung cancers that we found, and then obviously we're doing a CT lung, we will find some incidentals, which we will move forward. Some are going to secondary care, such as ILD. Some we might find severe coronary calcification, so that might go back to the practice. And then we have found some other cancers as well. So it was just to let you know about this program, and yeah, do let me know if you would like to sign up, and we can take that forward with your practice. Thank you.
Thanks, Jane. So I think probably just to kind of also just add to that ultimately, you know, that these kind of pilots are incredibly useful and helpful for our patients, and I would certainly encourage GP surgeries within those boroughs to take this on. We know that within the NHS long-term plan and within the cancer strategy, we're trying to change do a major stage shift so that 75% of patients are diagnosed within stages 1 or 2, and that's, you know, it's a huge target for us, and in order to achieve that, we would need to improve our screening. And so outside normal national screening programs within lung cancer, this is a pilot for us to help understand is that whether we can actually improve lung cancer detection at an earlier stage. There are a couple of questions actually here already in the chat box, and so Susie, before I actually hand over to you, I wonder whether we could just answer these questions. And
that's your plan. So one's for me actually is about other boroughs, and I was just going to say actually yes, we're on the pilot, and there is a plan to roll out nationally and locally. So yes, that will be that is the plan. It's kind of being evaluated nationally, but the plan is for this to eventually become a national pilot. But I think there'll be a kind of slow rollout, so we'll gradually move across the boroughs. Yeah. And then the other question actually was for you, Susie, about direct access to CT, although I'm sure Abs, you'll want to come in on that too, but about giving GPs direct access to chest CT.
Abs, do you want to say anything about that, or shall I?
Yeah, I guess a bit of both, really. It'd be really good to hear your take, Susie, in that. So I think direct access for CT is something that is not currently available within North West London. We know that there are advantages of direct access imaging from primary care. Advantages being that we may avoid a secondary care referral, and also we are able to make a decision for a patient where there is one question where we have a kind of yes or no question where if we get that answer, we can make that decision for the patient and save a secondary care referral. I think things to think about would be, I would probably suggest that those if we are thinking about direct access imaging, where there is a more complex structure of symptoms and a CT scan may not provide your definitive answer, and you may still need an onward referral, and you're still worried about a cancer, I would consider site-specific or non-site-specific referral. So that means down a 2-week wait pathway through a site-specific RDC or a non-site-specific rapid diagnostic centre. And also think about incidental findings. So if we have chest CT that are out there, how do we manage this? incidental findings. So these are all questions that are being discussed at a kind of ICS and alliance level, and I know there has been a lot of work done about it. You may have heard about the concept of community diagnostic hubs, and there is some work being done to understand our diagnostic provision within that. So at the moment, there is no access for CT, but I can certainly see the argument for that. Susie, what do you think?
So I think everything you said, really. I think the only other thing is that at the moment, as you guys know, there's quite a lot of issues with direct access to chest X-ray. So I think we need to get that sort of first step back up and running after the pandemic, and then the next step would be considering about CT. I think if I was a radiologist, I would be sort of a bit quaking in my boots about the issues that they're already having with availability and with resources and things. And I think at the moment it's unlikely to happen anytime soon. But as Ab said, all the discussions are going on. There are definite advantages for direct access requesting for CT for GPs. It's just at the moment, I think there isn't going to happen at the moment. We need to get our chest X-rays back properly direct access first.
Yeah, and that's a really good point. And there are some factors which are out of our control, such as workforce, and radiographers are we are struggling with the recruitment of radiographers in performing imaging, and that's particularly been found in the breast pathway, but this is also through other pathways as well. And so everything needs to be in line before this can actually be done, but it's definitely a discussion point and something that we are aiming to look forward to in the future. Thank you. So actually, next, Susie, if I hand over to you for the next part of our presentation.
Cool, thank you. Yeah, so I'm Susie. I'm the Lung Pathway Group Chair for RMP. I'm also the Lung MDT Lead at Imperial. And we're just going to talk today a bit about lung cancer, what's happened during COVID, which Abs has already told you a lot about, and maybe a bit more about the reasons behind that, and then what we can do to try and bring things back to how they were before. So we've already heard that we've had fewer 2-week wait referrals, fewer all referrals into the secondary care during the pandemic, which obviously makes sense and very good reasons behind that. But the knock-on effects of that have been that we've got later presentations of patients, and that's borne out in the data that shows that more patients are undergoing palliative care rather than having curative radical treatment options. We're missing cases, or we were missing cases in the initial part of this year, and now they're coming in, but as later stage presentations. And so those knock-on effects from the pandemic are being very keenly felt at the moment by the patients and the lung cancer pathway. The reasons behind those changes were obviously because all the outpatient facilities and diagnostic facilities very much shut down during the pandemic, quite appropriately, and to realign resources where they were needed on the front line. But then there were other things like changes to the 2-week wait referral, triage of the 2-week wait referrals, so really only bringing in the very high risk patients. And then the other things where our incidental pickups also would have gone down. So community cardiology, doing CT coronary angiograms, we pick up a lot of incidental nodules and things there. Trauma cases fell massively during the pandemic because people weren't out and driving around and doing all the other things that lead to trauma. And so those incidental pickups of the early diagnosis, really in the stage 1 and 2 disease, really fell off massively during the pandemic. So what do we need to do about it now? Well, a lot of what we need to do is already being done, but we need to raise the public awareness. So the RMP put out their campaign about coughing for 3 weeks and to the public, but we need to get that more to the communities who don't see that sort of thing and aren't aware of that. We need to get people to come forward. So we need to be thinking about lung cancer and keep it at the forefront of our minds to suggest perhaps these patients need to come forward. And then we need to make our referrals as good as possible. And the RMP aim overall for all cancers, in line with the national cancer team's targets, is all about earlier and faster diagnoses. So if we go to the next slide, I thought this slide is important to talk about because why is it important to get early rapid diagnosis? Does it actually make a difference? 2 weeks doesn't sound like that long a time, but does it actually make a difference to get these people into the pathway? Does it matter if we do it this month or next month, refer them in another course of antibiotics, see how they are, or should we refer them in now? And I think for many patients, obviously, it doesn't make a difference, but actually with lung cancer, the prognosis changes drastically with the increased stages of the tumour. And we're thinking just about the tumour growth itself, so nothing nodal, nothing metastatic, just about the tumour growth itself. small changes in tumour size have a really big impact on survival. And these lung tumours can actually, although some of them can be around for years and years, adenocarcinoma, spectrum lesions, for example, some of the squamous cell carcinomas have a very short doubling time. So if you think about a 62-day pathway, that's from referral to when we're first going to treat the patient, the tumour may have almost doubled in size. The median squamous cell doubling time is only 97 days. So if we are on target and everything runs smoothly, that tumour really could have almost doubled in size in that time, and that could bring it up the stages dramatically and really impact on the treatment options that that patient has. So it really does make a difference to try and diagnose lung cancer as early as possible. And even those short time differences make a difference. And the big paper that this part of this came out of was called Millimeters Matter, which sounds a bit dramatic, but I think it's important to remember that with lung cancer, that actually weeks can make a difference. So we need to get those patients in as efficiently as possible. The next slide, please. So why was lung cancer particularly affected by COVID? Well, I don't think it was particularly affected, but it had some very particular things about it that caused the problems that we saw. And one is that the symptoms are very similar. Apart from anything else, lung cancer often is completely asymptomatic, as we know. And then if you do get a cough, at the time of the pandemic, if you were coughing, well, you had COVID. And most of the time people would have had COVID. And then if you kept coughing after that, you still had COVID, and then you had long COVID, and then you had post-viral hypersensitivity, etc. And all of those things are completely valid. So how do we pull out the patients who need a 2-week wait referral? We need to be thinking about lung cancer from those who have, I was about to say a just post-COVID cough, but there's no just about it. But so how do we pull out those differences? And this slide is nice, and it's an illustration that I'm sure that you guys have seen before, but it helps to bring out those differences. And I think it's partly about the acute onset being brought on perhaps by an acute infection episode where you had COVID and then you keep coughing afterwards. That makes it feel more like it might be post-COVID. But the patients we worry about are those patients who are high risk and they've had a sort of cough and they say, how long has it been going on? I don't really know. It's been there a while, definitely more than a month, rather than, oh yeah, it's since I was unwell. And then also on this slide, there are other things to think about. For example, obviously, if you're having hemoptysis, that's a big red flag. If you've got finger clubbing, lumps and bumps anywhere up around your neck, etc. And then, although smoking is a very important thing to think about, and the vast majority of patients with lung cancer are smokers or ex-smokers, we need to remember that some patients have never smoked and that it is still a big and common cause of cancer, and particularly in groups of Asian women who are more likely to have those particular genetic mutations that lead to lung cancer, but then also lead to more susceptibility to the newer treatments. So it's really important to think about those patients early as well. Okay, so this is useful, and hopefully the slides will go out, and it's worth just having as an aid memoir in the back of your mind about how to pull out the difference between lung cancer and COVID. And next slide, please. Oh, God. So then what happens? So you've decided that the patient might have COVID. Then there are two options, aren't there? There's one, send a patient for a chest X-ray, and obviously see what happens, and we'll talk about that in a minute. And then the other option is about the 2-week wait form. Now, the 2-week wait form is controversial, and it's both the bane of my life and the sort of reason of my job. And I'm sure you guys have issues with the 2-week wait forms as well. They're being reviewed on a London-wide level, all the different 2-week wait forms. I think actually there won't be very many changes that come out. And even within the pathway group and within the lung consultants, we have very different approaches and very different ways that we would like this form to look. But this is how it looks at the moment, and I suspect this is how it will continue to look. What's the point of a 2-week wait? Well, that's another thing that's controversial. So the point of a 2-week wait is to refer patients in on an urgent pathway if you have more than a 3% suspicion that this might be lung cancer. So that means, as the accepting person, 97% of the patients that I'm seeing on this pathway aren't going to have cancer. Now, depending on how you look at that, that's a great thing because you're essentially screening, although that's the wrong word, a large population and picking up 3% of patients who are going to really benefit. However, on the other side, that's a bit irritating as a secondary care person because you feel like you're wasting your time with those 97% of patients. And that's where the controversy within the lung consultants comes. And it may be why you sometimes get 2-week waits being sent back to you. So what I would say to you as a primary care population is that the way to get patients into the service is by filling out the form as fully and as comprehensively as possible. And also, if you are concerned that your patient may have lung cancer and you genuinely think they may have lung cancer, then be empowered to argue back, if you see what I mean. Some people are really not going to like me for saying this sort of thing, but it's true. But the more you put on that form, the more information that you have, as we have, as to why you're concerned that this person who we think clearly doesn't have lung cancer might have lung cancer, the more likely we are to get them in. And the things that really help with that are filling in all the boxes, making sure that we know their performance status, and we'll come back to talk about that a bit more at the moment. Making sure that the patient understands about the 2-week wait form and what will be expected of them from the referral. There's nothing more irritating than spending a lot of time organising a CT, etc., ringing up the patient who says, "Oh no, I'm going to Sardinia for 3 weeks." It's like, what? And then the other thing is, of course, about the chest X-ray. Now, so if we go to the next slide. Oh yeah, so chest X-rays. Ideally, patients coming in on a 2-week wait would have a chest X-ray first. It's not mandatory, but it makes a big difference. It helps us to be able to triage those patients forward even quicker if there is an abnormality on their chest X-ray. So thinking about those millimeters matter thing, if we see somebody with an abnormal chest X-ray, we will then use the National Optimal Lung Cancer Pathway to get them in to a straight to test, although it's not quite straight to test, CT scan within the next 72 hours. So you can bring your 2-week wait when you get your CT back down to only 3 days. And so that's why the chest X-ray is really important. I understand that if you've got to wait 2 weeks for a chest X-ray and you think the patient is high risk anyway, it's not ideal. And that's where what I mean by we really, as a secondary care population, really need to sort out our direct access to 2-week wait, so that you can send your patient up for an urgent chest X-ray on the same day, and then use that to make the 2-week wait referral, rather than having to wait for that chest X-ray, then wait to make the referral, etc., etc. It all just adds time. But a chest X-ray is really important and helpful, but it's not mandatory. If you're really concerned about the patient, do the 2 things at the same time. Book them their chest X-ray. If we get in there with the CT first, well, we'll cancel the chest X-ray. If not, then we've got that information to know how to pull the patient out. But then there's a whole area, isn't there, about safety letting that chest X-ray. If you're going to send a patient for a chest X-ray that then turns out to be abnormal, you want to know that that's going to be actioned. And again, that's something that is not completely consistent across our patch. The ideal thing would be if there is a genuine concern about a malignancy on a chest X-ray, that will come straight into the lung MDT group or lung MDT, and we as in the secondary care providers, contact the patient, sort out the CT, and each trust does that in a slightly different way. For Imperial, we will contact the patient, we will book the CT and get them in. At London Northwest, the radiologists will organise that CT scan and then ask the GP who referred him for the chest X-ray to send the 2-week wait. So every trust has a slightly different approach, which is confusing and irritating, and it's something that as a pathway group lead through RMP, we're looking at to try and standardise, but it's it's difficult, and it's difficult at the moment. But ideally, the trust should pick up the responsibility for that abnormal chest X-ray. However, it's also really important that if you're sending patients in, that you get the result and that you safety net some way of making sure that that result is checked and actioned. If the chest X-ray is normal, then you still have an ongoing concern, then you can still refer in on the 2-week wait pathway, or to the general chest if you think actually it was a less of a lung cancer concern. The other thing that happens sometimes is that you get a report back saying this looks like infection. Very few secondary care respiratory services at the moment have the capacity to take up all those all those query infection 6-week later chest X-rays. So that's an important thing to safety net and make sure that that 6 weeks chest X-ray does happen, because if it's still abnormal, then that's even more important that they come into the trust. And if it's the second chest X-ray and the radiologist reporting knows that the GP's on it, that's sometimes where flags into the secondary care service get lost. And these are all things that we're aware of, and we try and add as many safety nets in hospital as possible. I think it's really important that you guys are aware of where our weaknesses are as well, if that makes sense. Okay, so next slide, please. Oh yeah, so I think Abs has just turned his video on.
No, that's really helpful, Susie. And I was just wondering, as a quick question, almost something that comes to mind, is that if a patient has had a chest X-ray and they go to that has been done at a secondary care trust and they found an abnormal lesion, and that particular trust has upgraded them to a lung MDT. If I, as a GP, if I've not done the 2-week wait yet, so I've just done the chest X-ray, would I get any feedback, do you think, that it has already been upgraded, or should I just do the 2-week wait anyway? Because I guess I'll be in a nervous position that I'm not sure whether this patient has been upgraded or not. What's the best thing to do?
I think that's a really good point. And because it's different across the different trusts, I think it's difficult to say. I guess the safest way to do it is to send the 2-week wait anyway. The worst that happens is we'll say, we've already got this, thanks very much. And maybe on the 2-week wait, there'll be some more information that we didn't have. So I think that's still beneficial to do the 2-week wait anyway, and maybe we should, that's a good point actually, we wouldn't necessarily feed back to primary care until we'd seen the patient the first time and you got a formal letter, which could be several weeks into the pathway from the initial upgrade. So I'd say I think probably do send the 2-week wait anyway. Worst comes to the worst, you're going to be told that we've got it anyway. But I guess it's belt and braces approach, isn't it? Yeah, absolutely. Now you're frozen. Oh no, he's gone. Okay, the other thing I was going to say is about the performance status. So performance status is really unfilled in very much in the 2-week waits that I receive, and I think it cannot be expressed how important it is. Again, it's about triaging the patients. Not to say if they've got a poor performance status, we're not going to see them, but we're not going to ask them to come in for lung function, chest X-ray, lung function, CT, bloods, and a COVID swab all on the same day, because they won't be able to manage it if they're a transport patient. But if we don't know that, then we might accidentally completely overwhelm them with information and requirement of various appointments and things in that first sort of interaction. The other thing is some patients you want to see face to face, and some patients you're happy with the telephone. And just the more information that we have in the referral, the more we can make the appropriate next point of contact. And I think that is just providing the most information that you can. And as I said, please tell the patients and explain the 2-week wait pathway so that they know that they're going to be contacted by the horrible, scary hospital team, and that we're going to ask them to come up, and that we may be giving them some bad news. Because again, there's nothing worse than sitting down in clinic, and I've done it. I've sat down in clinic with a patient and said, "Hello, Mrs. Blocks. The good news is you don't have lung cancer," and they're like. And they're horrified because they didn't even know it was on the list of things they're worried about. So there's me thinking I'm being lovely and telling them straight off. And as far as they're concerned, it's the most traumatic thing that's ever happened. And they haven't even got lung cancer. So you know, you're damned if you do and you're damned if you don't. But the more information to everybody, the better. I think that the referrals and the whole pathway will work a lot more smoothly. We're very likely to do a CT before we see the patient. It's just more efficient, and there are very, very few doctors who will confidently say about a patient who is high risk, this patient does not have lung cancer. It's a bit of a, give me your MDU and your GMC number sort of moment if you're going to do that. And I think most 2-week wait lung cancer doctors will be doing pre-CTs in almost all patients. And the best way to do that is before you see the patient, so then you can reassure them immediately that there's no problem, or you can start them on the pathway if there is a problem. If we have seen a CT scan recently, or we have seen the CT scan, we're unlikely actually to see the patient. It will be a telephone call, and in some trusts it will be a letter just saying you don't have cancer. And sadly, we just don't have the capacity within the fast track service to deal with all those other things that have led to the referral. And many patients find that very frustrating. They thought they had a cough and they were coming to get their cough sorted out. And I say, I'm really sorry, you're in the cancer service. You don't have lung cancer, but now you need a referral into the general chest clinic. And unfortunately, that is just about capacity. We would love to try and help with more of those things. And sometimes we'll give a bit of advice and try and pick out some things, but it's not going to get you your ILD treatment or your treatment for chronic cough or asthma or anything like that, unfortunately. And I think that's really important that the patients understand that as well, because otherwise they're disappointed by the service that they have, even though they've had brilliant news that they don't have lung cancer, which is great. And then, yes, some of the more controversial people like this final phrase on this slide. The likelihood of us seeing the reversal depends on the completion of the form, which is true, but there are probably politer ways of putting it on the form, on the slide. Okay, next slide, please. Oh yeah, so this is what we are then trying to do. We've got this new thing called the faster diagnostic standard, which is a new target that came out, which actually was meant to come out before the pandemic and then it got delayed, thankfully. But now we're expected to make a diagnosis or rule out a diagnosis of cancer within 28 days of referral. That is not a lot of time, and it's going to result in the 2-week wait turning much more into a straight to test sort of pathway. 95% of patients, this is an old slide because it says by 2020, 95% of patients need to be told that they do or don't have cancer within 28 days. And if they do have cancer, they need to be given a treatment plan, or at least a decision to treat and a vague idea of what the next steps will be. And actually, it's easy for the 2-week waits who don't have cancer to tell them within 28 days, you'd hope. But actually, the patients who may or need those further investigations, it's more difficult. The target of 95% is okay in lung, because as I said, if you think about only 3% of the referrals should have cancer. So in a way, it's not a very helpful actual number to hold anybody to. But the idea is important, that we need to get these patients onto the later stage of the pathway or off the pathway reassured in 28 days. Because being on a pathway, if you don't have cancer, is obviously extremely anxiety provoking up to that point when you get the good news. Next slide, please. And this is what we're using, the National Optimal Lung Cancer Pathway. This is, you guys obviously don't need to know the detail, but this is what we're using to try and get patients into the treatment end of things as quickly as possible. At the moment, it's a 62-day pathway, so from the day of referral, which interestingly actually starts at -3 days for reasons best known to the team who developed this. But anyway, and then we have 62 days to get the patient to treatment. The ideal will be over the next few years to be working to a 49-day treatment pathway. At the moment, we are a long way off that, and particularly with the backlogs from the pandemic and everything, it is more difficult getting people through this pathway than it used to. And there are many issues that we're having at the moment. Access to e-bus, access to PET scans, etc., are all slowing things down. So that's having a direct effect on our ability to get the patients through the pathway. But the quicker and the more efficiently we can get them in at the early stage with the better quality of referrals, then the more we can get patients through in a slicker and more efficient way. And next slide, please. So the key messages, I think, from my waffling on were going to be: think lung cancer as much as possible, even in non-smokers, and refer in those patients who you are worried about, because the whole thing is about earlier and faster diagnosis, because we can improve the prognosis so significantly if we get those patients in at an earlier stage. And even in the patients who have non-curative disease, so stage 3 and stage 4, if you get those a few weeks, months earlier, it really is better. So the difference in survival between a really nasty stage 4 and an earlier stage 4 is marked. So, and if we can now, with the newer treatments and things, the PD-L1 inhibitors, TKIs, etc., where appropriate, we can really intervene and make a difference. So earlier, faster diagnosis is the take-home message. Get a COVID swab if you're worried that they might have COVID. Try not to send active COVID into the hospital. It has happened, it will happen, it will continue to happen. It's often the doctors, but the more swabbing we can do, the better. If you're organising a chest x-ray, which we would urge you please to do, make sure it's safety netted, and I think probably do send the 2-week wait. And then if it's not a site-specific thing, if lung isn't on your top of your list, there's more and more access to the rapid diagnostic cancer clinics, so the RDCs for non-site-specific vague symptoms. And that's really a difference between Europe and England. We see that patients can get into these early diagnostic centres much quicker than they can in the UK. And there's quite a nice graph that I don't have here that shows about the quicker you get into the first diagnosis and the more access you have to sort of specialist diagnostics, the better your outcomes from all of cancer. So this is the UK's approach to try and become a bit more European. At the same time as Brexit. Even patients who have a normal chest x-ray, 23% of them of the cancers, 23% of those had a normal chest x-ray, not 23% of patients with a normal chest x-ray have cancer. That's obviously the wrong way around. And yes, try and send patients in as quickly as possible. The other thing I think it's important to say is that patients who have COVID or have had COVID can also have lung cancer. So if you're not happy that they've just got a post-COVID cough or that this is all COVID, refer them in anyway. we have actually had very few patients who have come through the pathway at Imperial anyway, who've had COVID first, and I'm not sure why that is. We in Northwest London have now caught up with most of our missing treatments, so I hope that there aren't a lot of patients sitting out there still, but it is an interesting thing that a lot of those patients who had COVID would have been in the high risk for lung cancer group, and yet they haven't really been coming through the pathway yet. And there are two outlooks, and that maybe sadly they've all passed away during the last pandemic, during the pandemic, or alternatively maybe they're going to come out of the woodwork in the next few months. I think that might be all I had to say.
Okay.
I think it might be. Next slide. Oh no, this is the last slide I was going to say. The other thing is, once we've made the diagnosis of lung cancer, we do our best to try and keep in touch with the primary care side of things so that we can all work as one team to try and help the patient. I know a lot of times patients will come to you guys to discuss stuff that we've discussed in hospital, and if anything isn't clear, certainly we would rather people asked and talked so we could all be singing from the same hymn sheet. And we always try and communicate as quickly as possible and let people know that the plan, you should get a flag for any new diagnosis with the same day or within 24 hours. If that's not happening, then let us know. The CNS teams are really essential at the heart of all of this and really help the whole world go round as far as these pathways are concerned. The other thing I'd say at the moment is that second opinions are very difficult, just in terms of resources, and I have certainly said no. And we're sorry, we will hopefully get back to doing that more in future, because obviously patients have the right to discuss that, but it's extremely difficult. And we will always review the case, we just may not see the patient. And patients and families need a lot of support, and it's a very difficult, scary disease. And I think that was the last slide. Yes, questions and answers.
Thank you, Susie. I mean, that's brilliant. That really gives us a really nice and succinct overview about the importance of thinking about lung cancer and primary care, and how we can best improve the early diagnosis phase for our patients, and a little bit about what happens in secondary care, the interface. So if there are any questions, please could we pop that in the chat box, but I might just kick things off just to help a little bit of our discussion. So please, anybody who's got any questions or any comments, you could raise your hand or pop it in the chat box. It'd be great to hear from everybody. I mean, you did mention about ECOG performance status, and I think everyone on the call here probably knows, as you very well described, the importance of putting that on the 2-week wait referral form. And I guess I wonder what I was thinking and trying to illustrate is that when I see a patient, sometimes they've deteriorated and their performance status may have been, say, a 0 or 1, and rarely they're quite sick now, and I'm worried about a lung cancer, and they may have deteriorated to a point of 3 or or worse. Which one should I tick? Should I tick the baseline performance status, or should I kind of put what they actually are right now?
I think in the performance status box, probably best to tick what they are actually now, but I think it's really important to write in the free text bit, but this is a recent thing, and until 2 weeks ago, they were doing fine. I think that sort of the rapidity of decline is really important to get across on the form, because it gives you an idea, we're looking for a small cell lung cancer, much more rapidly progressive, is this somebody, we need to get up in 1 day rather than 3 days, all that sort of thing. So again, the more information we have, the better. And if there's been a significant change in performance status, I think that's really important. But even in patients who have a very high burden of disease, and that's what the cause of their decline in performance status, it does sadly make treatment options much more limited.
Yeah, absolutely. And I wonder whether, I'm just thinking out loud, and that when you have your lung MDT, having that piece of information, if you haven't met the patient on that pathway, and you're due to invite them in, if you've got an idea of what they were and what they are now, can really help in considering what the best thing is for that patient. So I guess as GPs here on the call, we know our patients very well, and we may have known them for a number of years, and so we can give a real accurate description of that. But unless we fill out the form properly, then that may not always be communicated. That's interesting.
I think the other thing just to say about that is performance status. If, for example, in patients with a pleural effusion, it can be dramatically changed by treatments or interventions. So another reason to get patients in soon. For example, if we're referring to the mesothelioma MDT, they want the performance status clearly documented after drainage. Okay, so and because obviously that can be extremely different if you have 3 litres of fluid in your chest if it's in the bucket instead. So really important to make that clear.
Thanks, Susie. And then I guess sometimes, because there are so many within Northwest London, there can be overlapping trusts, and there can be imaging that's going to be done within the community. Just thinking, do you sometimes get those reports at Imperial for those that are done at Chell West, or should we make sure that on the form that we've put all the chest X-ray results, everything that's historical, or even if they've had some cross-sectional imaging, would that be helpful, or do you actually automate that within secondary care yourself?
If only. So there is a plan for the new, I can't remember its name now, but there is a plan for a massive radiology warehouse where all of Northwest London Trust signing up to it will have access to each other's imaging. But sadly, that is not the case yet. I think the important thing is to know where the scans were done or the chest X-ray were done. Obviously, the patient may have had their chest X-ray done at Chelsea and want to be seen at Northwick or whatever. So it's just important to know where it was done so that we can get it over, because if we can IEP them, it's just irritating in the past. So where the chest X-ray was done is really vital. And the other thing is to make the patient aware or to check if they've already been picked up by that trust's pathway, because for example, at Northwick, if you have an abnormal scan, you're going to be picked up by that pathway. So you don't need to be on both, and it doesn't matter which one you are. That should obviously be patient choice. But I have had patients who we've scanned, and then they come to the clinic and say, well, I've had 2 scans. Does this one say the same as the one at Northwick Park? And you're just like, ah. So just about letting the patient know that and say, don't embark on both pathways. It's just a waste of resources, really.
Well, that's really interesting to know, because I guess we don't get the images, we'll get the reports, as you know, and then so it would be helpful for us not only to put the report if they've gone to various different trusts, but also to say where they've come from, because you want to import those images, and so we should make that clear on the 2-week wait form.
And weirdly, the reports themselves often don't say in the bit that gets transferred over where it was done. So unless you recognise the radiologist's name, you may not be able to tell where that chest X-ray was done.
That's interesting. I remember I had this one patient a few years ago who actually presented with a right shoulder or scapular pain, and he ended up having an MRI or something done within the private sector, and then had some imaging done which actually showed that he had a pancreas tumour in the end. And we did a 2-week wait referral down, and there was some real tricky, it was quite difficult to get some of those images through, and he ended up doing everything all over again, and he got quite upset and frustrated about that delay. And so that learning from us was to make sure that everything was communicated at the point of referral to make it easier within secondary care, and things don't, as you said, neatly link up, and particularly between the private sector and the NHS. Cool, that's really helpful. So, and there are other things sometimes we do in the community, like spirometry, and I guess our high-risk patients, we will have COPD, and we'll see them regularly as part of our kind of long-term chronic health disease monitoring and management. Should we be, you talked about lung function tests for those individuals that have a suspicious lesion on imaging. Is there any value in us including spirometry on the 2-week wait, or you're going to do something more detailed anyway?
So I think if you're doing it anyway, the information is really important. I think if they're going to need to have any intervention of any description, a CT guided biopsy or any treatment, they will need formal lung function, including their transfer factor. So the spirometry, I guess, will get done again. So from the point of view of not wasting resources, don't do them specially. But again, they do give more information. So if they're being done anyway as part of the COPD check or anything, then definitely include the information.
Cool, thank you. I've been talking a lot and asking lots of questions. Has anybody else on the call got any other questions that they'd like to ask Susie before we go back to the slides? No? If there is something, please just pop your hand up or whack it in the chat box. So, Sophie, do you mind just bringing the slides back up, please? Thank you. Right, so we're kind of at the business end, and hopefully we've got through lots of key information and we've educated everybody about the importance of lung cancer. So I'm just briefly going to talk about the resources that are available for primary care and patients. Next slide, please. So we will circulate this with the recording, and so you can actually go on these hyperlinks and have a look. But we've put together some resources for primary care, but also patients, as I said. So if you look down this list, there are things that are a little bit more obvious to us, like our NICE NG12 guidelines, which I'm sure we all refer to and are aware of. But there are some other kind of helpful resources here as well. So just drawing our attention to Gateway C, where there may be there are some lung cancer modules. The Primary Care Respiratory Society, which provides some really helpful information about chest symptoms. And then see through the symptoms at the top there, and so that just a little bit of education about the importance of understanding the presentation of lung cancer symptoms. The consideration of lung cancer in never smokers, a hidden disease. So that link, it's important to know. We talked a little bit about, and Susie referenced those individuals, particularly Asian women who have never smoked, may still have a lung cancer, and we must think about them and those that present with red flag symptoms. And they may have the EGFR mutated lung cancers where targeted therapies such as tyrosine kinase inhibitors may be helpful for those individuals, and they can have a very good prognosis and less kind of treatment morbidity. But so it's important to think about that. Macmillan Cancer Support have a very helpful a link on lung cancer, so please do have a look at that. And then obviously there's the fingertips data on PHE as well. Next slide, please. So just a little bit more, smoking cessation is important, and we have an opportunity when we do these referrals to a 2-week wait lung cancer clinic, when we see our patients or speak to our patients, to have that educational moment. And it is difficult now within primary care, and I totally understand the pressures that we have, and often time will be taken in explaining the importance of attending the 2-week wait appointment, the fact that they're going to a suspected cancer clinic, doing the referral and doing everything that is around about safety netting that patient, and that does take time to do it properly. And one may therefore assume that smoking cessation is going to be dealt with within secondary care. But as Susie told us, that's also a very stretched pathway, and often these patients aren't seen within secondary care. They may go and have a CT and then come back and have a virtual follow-up or a letter. So we have an opportunity to capture those patients to say, actually, you've come in with serious and concerning symptoms. We are thinking about cancer, and we are using this to make sure that you do not have lung cancer, or referring you down a 2-week wait cancer pathway. And there is an opportunity to think about smoking cessation there. And that moment, that educational moment, we know is very important. And so please do think about that. And there are some resources that are there as well. These are some resources for patients. So we know empowering our patients is incredibly important. It improves the way that they present to us within primary care. And particularly when it comes to early diagnosis, not just within lung cancer, but with everything else. It's if patients are ready and able to come and present to us within primary care and are aware of and have that knowledge of red flag symptoms, that will empower them in order to come and interact with us so that we can help them and get that early diagnosis in. Now, not only that, afterwards, if there is a cancer diagnosis that is found, there is lots of information that's available out there. I'll just put reference Macmillan Cancer Support, Cancer Research UK, and the Roy Castle Lung Foundation. So they're very good resources, and please do send these on to your patients. EGFR positive and ALK positive UK, these are helpful for those with mutated lung cancers. Now that may already come through your or the patient's lung cancer CNS, but think about these. And at the bottom there, we've got the lung nodules patient information video, and that's actually a really interesting one, and I'd probably encourage you to have a look at that. And it's something that Susie and her team have been doing with RMP, and that there are incidental findings that are sometimes picked up on CT scanning, which may leave patients with higher anxiety about, I have a lung nodule and what happens next. And there is some information, a patient information leaflet that's been developed from that, on that, and a YouTube video, which is actually very interesting. Jane, you had your hand up.
Yeah, thanks. I was just gonna say a little bit more about the film, because I've been involved in that. So it's on trust site in their respiratory department, but also it's on our RMP site as well, and it's also translated into 4 community languages, and there's a leaflet to accompany. So yeah, so if you do have patients coming back to primary care saying, I've been diagnosed with these lung nodules, what's that all about, then this hopefully will be a film, and it features Susie as well. So yeah, it's a really good kind of local resource. So just wanted to highlight that.
Shaking your head, Susie. Does it not feature yourself?
I am on the video, but I wouldn't put that as its selling point.
No, it's really good. It's nice. It's a kind of mixture of professionals and animation.
Thank you. And just finally, really about this, resources for patients. Now, within primary care, we know that with the new QOF, we are expected to, and we're being measured to, reach out to patients with a new cancer diagnosis within 3 months of their diagnosis. Now, that can be tricky because patients will have multiple secondary care appointments in that time. They may not feel ready to engage with primary care, and it may come later. So it's about how do we reach out and how do we engage with our patients, and having some resources available. So say for lung cancer, such as here, will help you have that conversation with them. So it's important for us just to have that within our kind of like our belts, that we can use that and will help you achieve your kind of your QOF targets. Brilliant. Just chat box. So Susie, a little shout out there from medical school friend rather than a question. So coming towards the end of this webinar, what I'm just going to do is quickly just summarize what we've talked about so far. So thank you, everybody. I mean, that's been really helpful, and I've certainly actually learned something today. And what we've talked about is the importance of lung cancer. We've talked about the recovery of 2-week wait referrals across our geography, across Northwest London. We've talked about the concept of missing first treatments and how that could have been a problem within lung cancer. And we've talked about models within Wandsworth where the data suggested that it was a bit more of an issue, but some learning that can be done from that. And we may want to explore that in our local practices and PCNs. We talked about the association between socioeconomic deprivation and lung cancer, so always something to think about. And we talked about the concept of never smokers, or those that have smoked very few cigarettes within their life. And lung cancer is still something that can happen. Although we do know smoking is the most important risk factor here, there is, you should not think they cannot have lung cancer because they've not smoked. And those are our EGFR mutated lung cancers. Within those, particularly those individuals of certain South Asian backgrounds in women. We talked a little bit about, and Susie highlighted the paper of millimeters matter, so the doubling time, for example, of a squamous cell, and the importance of therefore moving swiftly. And so within primary care, for us to think about lung cancer early. There was a very good slide about the overlap between lung cancer and COVID symptoms and the guidance of how to differentiate between those two, because clearly that's been something that's been on our minds within the last year or so. We talked a little bit about filling out the 2-week wait referral form and making sure from our point of view that all details are filled out, because pretty much on that pathway, that patient is moving very quickly down a fast diagnosis standard, and the more information that we give on that form is going to help that patient and the secondary care team come to a decision. Chest x-ray. It's very important that we organise chest x-rays and we think about chest x-rays when clinically appropriate. If we are referring a patient down a 2-week wait and they're going down to have a straight test CT, if they've had a renal function, so an EGFR within the last 3 months, please make sure that's going to be on your 2-week wait form. That should be auto-populated, but it's worth double checking just to make sure. Now, that's important because contrast enhanced CTs can only be done if we know that the renal function can tolerate that. And sometimes it's also important on our 2-week wait forms to make sure that we have the practice bypass number or a direct email address, because secondary care can sometimes want to get in contact with us, and it's helpful if we can do that. We talked about performance status and the importance of documenting performance status and the difference between kind of an acute and chronic performance status and how that will help decision making. And we've talked about the faster diagnostic standard and how patients can move quickly through. There was a little bit of discussion, well, a mention of non-site specific rapid diagnostic centres, certainly by the end of March 2022, so very soon. There is an ambition that the entire of the North West London population will have a coverage for non-site specific RDCs. Currently, we're live at Chelsea Westminster, West Middlesex and London North West, when we're soon going live at Imperial, and thereafter will be a provision within Hillingdon. And so then we talked a little bit around about new diagnosis and support that we can offer for our patients with newly diagnosed lung cancer, a little bit about information leaflets, and also some education materials for us in primary care. Good. Okay, so I hope that's been helpful. And can I just ask everybody to think about helping us with feedback? If you could just click on that link and complete our survey, and we will have maybe what we could do, Sophie, is just put that in the chat box as well, and then that would really help us in shaping kind of future educational events. We will have monthly webinars hopefully coming in soon, and we're not going to do one in December because of time pressures, but the next one's going to be on hematological malignancies in January, and the data's there. So please do look out for that, and please do join us, and that will be simply a lunchtime webinar. Great. Okay, and if you please just use this email at the top for to request a presentation if need be. I just want to take the opportunity to thank our team. So thank you so much, Susie, for your time and effort in coming here to present today and helping us within primary care. Thanks to Jane and thanks to Sophie as well. Are there any last questions or comments from anybody here? Great. Okay. Well, I guess back to work, guys. See you soon, and thanks very much for attending.
Thank you. Thanks.
Thank you.